Good morning, everyone. My name is Eva Feldman. I'm here with Mary Riley, and we're very pleased to welcome you to the plenary session this morning on neuropathy. And I'm very pleased to introduce our first speaker, Professor Mary Riley, who will speak on inherited neuropathies from genes to clinical phenotype.
Thank you very much. First of all, I'd like to say thank you to the organisers for inviting me to speak. So I'm going to talk on inherited neuropathies. Okay. And I'm going to start my talk by just introducing what I'm going to talk about and then really talk about genotype, phenotype, whether it has any role in 2018. So when we think of the inherited neuropathies, we tend to divide them into two: those neuropathies where neuropathy is the sole or primary part of the condition, and those neuropathies where the neuropathy is part of a more multi-system disorder. And the first group are the traditional diseases you think of when you think of inherited neuropathies: CMT, hereditary neuropathy with liability to pressure palsy, the hereditary motor and the hereditary sensory neuropathies. And if you think about patients, many patients present with the complications of motor involvement. That is distal wasting and weakness with foot deformity, gradually ascending to involve the upper limbs. Whereas if you present with sensory neuropathy, you tend to present with the complications of sensory loss, such as ulcers, osteomyelitis, amputations, and Charcot joints. But it is a spectrum from pure motor to motor predominant, to classic motor and sensory or Charcot-Marie-Tooth disease, to sensory predominant, to sensory only. So when I mention CMT, really, I'm referring to the whole spectrum, and we no longer tend to divide them into separate entities. But of course, inherited neuropathies also are part of many diseases where there are other systems involved. For example, TTR amyloidosis or familial amyloid polyneuropathy, where there is neuropathy with autonomic involvement, high incidence of cardiomyopathy. You can have myopathy and vitreous involvement. And I have a particular interest in this condition because it was the first hereditary neuropathy I studied. And I studied a group of patients in Northwest Ireland and found they had a particular mutation. And when we looked back, we worked out that most of these patients had moved from Ireland in 1845 when there was a famine, and that famine had 1 million people immigrate. So it turned up in places you would expect, like the US, the UK, Australia, and luckily the US keep really good records of where people came from and when, which is how we worked out that it was the 1845 famine. And in the UK, despite there being 46 different mutations described in TTR, the Irish mutation accounts for half of the population. So hence my ongoing interest in this complex neuropathy. But does genotype, phenotype matter? So we now can find variations very easy by doing all kinds of sophisticated testing. And we're increasingly developing gene editing therapies that are disease agnostic. So does it really matter about the gene and the phenotype? And I would argue that it very much does, particularly when we think of diagnosis, prognosis, and treatment. And I will address each of these in turn. So first of all, from a diagnosis point of view, thinking of the simpler neuropathies, that is the sole neuropathies, we know that there are over 100 genes. Nobody is ever brave enough to give the exact number because they're always going to be out of date. And we also know that these still can be divided into those that primarily affect the myelin sheet, called CMT1, but I no longer refer to the axonal ones of CMT2, because really all of the axonal inherited neuropathies fit into this one. So it includes the motor neuropathies and the sensory neuropathies. And diagnostically, it is much easier. We have still got single gene analysis, but we have panels, exome sequencing, and whole genome sequencing. And in all our laboratories, there's different combinations of these that are used, but increasingly there's a gradual move towards whole genome sequencing being the norm. So it is much easier to find variations, but it is very difficult to work out which one is the real one. Now, there are many things that are getting better, which I will not address today, like the predictive programs, which improve as we know more about the function of the genes. What clearly is improving is our control data, but it still is ethnically not diverse enough. So when we have patients from certain parts of the world, we really do not have any idea of what is normal in that population. But as a clinician, when you see someone with a phenotype and with a genotype, you're trying to work out, is the genotype right for the phenotype? So traditionally, we saw patients we looked at the phenotype and we asked for particular tests, and we still do that. But increasingly in clinic, you have a patient come to you with their genetic result saying, is this relevant? And that means you really have to look at the phenotype in some depth. And although we are seeing hugely increasing phenotypes with genotypes, there has to be some rationale. So if somebody comes with a genetic result and they have a mutation in a protein which isn't expressed in the peripheral nerve, well, that's not going to work. And similarly, if it doesn't segregate within the family, it isn't likely to be the causative gene if you do the phenotyping properly. And as a neuropathy person, that includes quite detailed neurophysiological testing. So let me take a simple example. If you see a patient with a typical onset in the first decade of a hereditary neuropathy with slow conduction and autosomal dominant inheritance, and they have the chromosome 17 duplication, you don't need to do segregation. You don't need to worry about predictive programs. This is 100% penetrant if you allow for neurophysiology. So this is the perfect gene in hereditary neuropathy. And in most European, UK, US populations, this accounts for about 60% of people with CMT. So it still is the most important diagnosis to make. And it still validates the use of neurophysiology. So the basic use of neurophysiology nowadays, in my opinion, is to differentiate CMT1A from the rest, because increasingly there's overlap in many of the rest. And what about this patient, getting a little bit more complex? A man, moderately affected, in a family with males much more severely affected than females and no male-to-male transmission, with the classic sign of more wasting in APB than first DIO, weaker APB than first DIO, and smaller amplitudes. So you're thinking quite hard before you see this patient, it's likely to be a JGB1 mutation, and it is. And JGB1 mutation is relatively straightforward because many people, including the Inherited Neuropathy Consortium, which is an NIH-funded consortium, have published series of patients. And most mutations in JGB1 are pathogenic, with 3 exceptions in 3 amino acids not conserved between mouse and man. So this is pretty easy because most mutations cause a loss of function. Therefore, in a male, the phenotype per age is more or less the same, unlike females who have the X inactivation issue. But what happens if you see the same type of patient and they don't have mutation? And this happened to me. I had a patient a few years ago, and then I had a number of patients. And this is where it goes back to phenotype. You'd think this has to be a JGB1 mutation, or why am I not finding it? And of course, the answer was in our own work and in others' work that had shown many years ago that you can't have promoter mutations. And when I looked at my series of almost 200 patients, 11% had mutations in the promoter, mainly in the 5 UTR, but also in the 3 UTR, which is very rare. And we validated these with a luciferase cell assay. But the point I want to make here is, if you look at how we do diagnosis, none of these would have found these non-exonic mutations, just whole genome sequencing. Of course, we've adapted our Sanger and adapted our disease-specific panels to find these particular JGB1 mutations. But exome sequence misses these, and 11% of JGB1 mutations are non-exonic. So every time you get a report or you see a patient with a negative result, think that it could be non-exonic. And that, of course, will be revolutionized by whole genome coming into practice. Now, what about the axonal ones? So the demyelinating forms, by and large, most amino acid mutations are pathogenic, by and large, whereas the axonal ones are much more difficult. If we take the commonest form, that is CMT2A, due to mitofusion 2 mutations, which is autosomal dominant. This is multiple different mutations. It has many polymorphisms, many novel mutations, about 20% are de novo, and there's no functional assay. And we and others have published the phenotype, which varies, but generally it's a relatively severe onset early disease, although there are patients who may be milder affected. And it's even more complicated because it's mainly dominant, but again, we and others have published recessive families and more recently semi-dominant families, where it appears recessive, but as the heterozygous parents become older, they get a mild neuropathy. So when you see an individual patient, this is difficult. But again, the phenotype occasionally delivers you gifts, and this is one. So we had been looking into this particular recessive mutation in some detail because there's a founder effect for a deletion in the UK. But in this particular patient, they had a deletion in one allele and the RH707 mutation in the other. And as well as neuropathy, they had multiple lipomata. And shortly after publishing this, we got contacted by a group in Cambridge who are very involved in fat, in brown fat, and I really knew very little about brown fat before this paper. But they looked into this in some detail and showed that if you have a homozygous 707 mutation or a compound heterozygous, you always get a severe neuropathy lipomatosis. And this used to be called Mandelung syndrome, and there are many causes of that. And I've seen a number of patients, and this is the most recent one, with a compound heterozygous with multiple lipoma, and this had been a 10-kilogram lipoma that had been taken from his back. So this is absolutely concordant with this particular genotype. And similarly, another patient I saw not long ago had a very severe cognitive disorder and an axonal neuropathy, such that they'd never learned to speak, had a what you call the R104W mutation, and I didn't know if this was pathogenic, but again in the literature there were a number of cases, including the first one by Wilson Marco in Brazil, that showed that every time you have this mutation you have cognitive abnormalities. And I'd like to make the point is this is why it is incredibly important to any editors out there that we have a repository for case reports, because they may seem it's more difficult to publish them, but it is the strongest validation tool we have for some of these mutations. So moving on, that's the easy side. What about the multi-system disorder? So we've known for a long time that you can get neuropathy with ataxia and you can get neuropathy with paraplegia. And there are common pathomechanisms which makes it no surprise that you see complex neuropathy syndromes. But my wake-up call was this patient. So this is a patient who was seen by P.K. Thomas when he was about 16 and had an axonal neuropathy, and the notes say query extensor plantar. I saw the patient when he was 22, and I said, axonal neuropathy, definite extensor plantars. And at that time, it was many years ago, we would have called this HMSN5, which was axonal neuropathy with upper motor neuron signs. The patient was lost to follow-up and turned up a few years ago, and now I would have called it spastic paraparesis with a neuropathy. He was much more spastic than a neuropathy. And in scanning, he had that classic disease of leukoencephalopathy with brainstem and spinal cord involvement and raised lactate. And he had a tRNA-sensitive mitochondrial gene, nuclear mitochondrial mutation, the DARS2 mutation. And, you know, if you looked at him years ago, you would have definitely said he had CMT. So I began to think of this in a bit more detail and looked at it. And when we looked at the complex neuropathies, we found 157 when we published this last year, and now it's up to 190 because we keep a very up-to-date database causing a complex neuropathy. And as you would expect, the common association is ataxia and spasticity, and then there are a very large list of rare ones. But surprisingly, I began to see patients with cognitive disorders and axonal neuropathy, and in my practice, I began to get these patients transitioned from pediatric practice with kind of long-term mild learning difficulties and a neuropathy, and I have no idea where they were in the past, but I seem to see them more at the moment. And when you looked into this, one of the first genes to be involved in this was dynin, which is described a number of years ago. And when we looked at our series of patients with dynin, these patients had the classical phenotype described with dynin, which is a complex congenital spinal muscle atrophy, also called spinal muscle atrophy lower extremity dominant. So these patients are born with lower motor neuron involvement of the lower limbs, with proximal and distal involved equally, and with normal upper limbs. So whatever this gene is doing, it's involved in the lower motor neurons in the lower limb development. But when we looked at our series, they had the classical MRI findings of semitendinosis and adductus preservation, but 30% of them had cognitive disorders with various gyral abnormalities. And then we had this patient who looked the same. Look at those legs, and they're grade 4. They're not that weak, but they're very chronically wasted. He had completely normal hands. But in his family, as they got older, they got a mild upper motor neuron involvement. And he had a mutation in a new gene we described, BICD2, which is an adaptor protein. So now we know that this retrograde axonal transport machinery is involved with the development of the lower motor neurons for the lower limbs and cognitive development, but maintenance of the upper motor neurons later on in life. So this is the retrograde axonal transport. And what about anterograde axonal transport, which is mainly driven by the kinesins? Well, again, we and others have shown K1F5A can have upper and lower motor neuron involvement, and K1F1A exactly the same with autism as well. So I now think of this group of axonal transport axonopathies as being a neuropathy, but plus quite a large degree of CNS involvement. And actually, the question is, why not? So when we think about what we've said for years, we've stood in talks and said, why are ubiquitously expressed proteins presenting as organ-specific, such as neuropathy? And I wonder whether that was actually the tip of the iceberg. And with our now ability to look at much more complex phenotypes, particularly early onset childhood ones, we're finding that the spectrum of diseases with these ubiquitously expressed proteins is much more complex than we had thought. And similarly, as we treat diseases, so with TTR amyloidosis, 15 years after liver transplants, to prevent the plasma TTR mutant being deposited in nerves, we're beginning to see a CNS phenotype because of the CNS TTR being produced. So people didn't live long enough. It will be very interesting to see what happens with type 1 SMA. We know it's ubiquitously expressed, and now that we're treating the disease, what will happen later on? So it's a new era of what we will be dealing with in hereditary diseases. But is it just the axonal transport proteins that have higher mental function disorders? No. This paper came out in 2016, and there were a couple of papers describing this MORC2 gene, which is a CW zinc finger involved in the chromatin. And very shortly after this paper, there was multiple other papers showing that, again, the spectrum of the disease is from a severe axonal neuropathy through to developmental delay, retinal abnormalities, and even a congenital SMA. And my first three families with this, one had very severe CMT2, but her child had CMT2 with learning difficulties. The second one had moderately severe learning difficulties with CMT2, and the third one has cerebellar ataxia, spasticity, retinal dystrophy, and CMT2, and learning difficulties. So this, again, is a very large spectrum of disease. And this paper, which came out from Japan, is a very useful paper because it shows this is the second commonest cause of autosomal dominant CMT2, but again, cognitive problems in 30%. So this makes us think of these axonal proteins increasingly being involved in complex diseases. So how does that change clinical practice? Well, in my clinical practice, when I have someone now with what looks like an inherited axonopathy, even if it's just a peripheral nerve initially, I have a much lower threshold for imaging. And these are some of the patients from the paper that we published: Fragile X syndrome, metachromatic leukodystrophy, etc., just because it is really important not to miss these other diseases. And I'm a bit more reluctant to give such a benign prognosis unless I have found the gene, because that's where you will make mistakes. And of course, finding a metabolic disorder or a complex disease has prognostic implications versus a straightforward CMT. So how does this impact on treatment? Why would we need to worry about the phenotype for treatment if we have gene editing treatments which are disease agnostic? So just find the gene, treat the gene, but don't worry about the phenotype. Well, I would argue that for these simple diseases like CMT, and I mean simple in terms of the phenotype, it is extremely important to consider this. And first of all, what are the therapies? There will be a talk by Michael Sarita and by David Kornblatt later on this morning about therapies, but I'm just going to mention the three types of therapies for inherited neuropathies. The first is generic gene therapy, and that is many of the things you will hear about in talks over the next few days: antisense, small interferon RNA, genome editing, and viral vector-mediated gene therapy. And in CMT, one of the examples that has come out late last year is an excellent paper on two different rodent models, one rat, one mice, in CMT1A, with successful treatment with an antisense with behavioral, neurophysiological, and pathological good outcomes. So that's a very exciting development. Another example is targeting the pathogenesis of the disease. That is, where we look at what a gene does, work out how it causes the disease, and try to target the treatment for that gene. And this is how traditionally we've tried to solve these conditions. And in this one, a disease I'm interested in, hereditary sensory neuropathy, mutations in the enzyme serine palmitoyltransferase cause a buildup of deoxysphingolipids, which are toxic to nerves. And it's from that we're exploring. And then finally, we'll talk about pathway therapies. So if you look at the list of genes, it's hard to imagine we will develop individual therapies for every gene. So we have to begin to think of pathways. And of course, that's how we learn about acquired diseases as well, by thinking of the pathways that genes have identified for us. And one of these, of course, attractive pathways will be axonal transport, because the length of the axon and because of all we know about the genes involved in retrograde and antegrade axonal transport. And we're working on some ways of modulating retrograde axonal transport. So these are just examples of the pathways. But again, why is the phenotype important? Well, the first thing is the phenotype variation in humans. If I go back to CMT1A, if you look at this disease, lifespan is normal in these patients by and large. So you need safe treatments. If you have an antisense therapy or a gene editing therapy, the risk-benefit ratio for someone with SMA that will die within 1 year of life versus a normal lifespan is completely different. So you need to be very careful that you have a much safer therapies. At least you can't trial therapies in humans unless your safety data is absolutely robust. And I think that's where you have to remember they are humans, because if you just think of the mouse data, it's really exciting. Secondly, we do see a huge variation of these diseases in humans. This is the classic length-dependent neuropathy. This is myotubular-related 2 with severe facial weakness, Jelson-related amyloid, JGB1 mutation, GARS mutation with upper limb involvement in normal legs, Sigma1 mutations with upper limb involvement with exquisite weakness of the extensors. And this poor patient I saw about a year ago with congenital insensitivity to pain due to an NTRK1 mutation, and by 19 he's bitten off his tongue as a child, he's an amputated right arm, he has Charcot joints of his knees, and really is very severely affected. You cannot model this phenotype of all these patients in any animal. You can model the pathways, but you will not model the disease. And when you're treating the patients, you need to think of the disease. So we need to think how to do that. And the classic pathway from gene to therapy, in the preclinical pathway, we've used animal models and various other models, but we need to think of how we use the human. Now, iPS cells have been a great move forward because they've allowed us to have a sample from the affected patient, but it is in isolation, it's outside the body. So we need to develop better tools of preclinical in vivo human testing. So something like a live imaging molecular interactome of the future that we can use to see how these genes affect patients. And secondly, the other thing about the phenotype is most of the genes, particularly in the axonal diseases, are ubiquitously expressed. So when we develop therapies, we may need to target the peripheral and central nervous system together. If we just target the peripheral nervous system, there may be off-target effects in the central nervous system. If we want to target the peripheral nervous system, we need to get into the peripheral nervous system, that is, cross the blood-nerve barrier. And as I said earlier, it may be that the phenotype, we've just seen the tip of the iceberg, and we need to be aware of that, and that if we just treat the peripheral nervous system, we may have CNS diseases emerging later on. The second thing is that in hereditary neuropathies, particularly the CMT, axonal loss is the cause of the disability. We've known this in CMT1A for years. Despite being a demyelinating neuropathy, we know that the patient's disability is proportional to the axonal loss as measured by CMAP amplitudes. And we've shown that recently by looking at neurofilament light chain as a marker of axonal loss, and shown in all forms of CMT, including CMT1A, it's elevated, and the height of the neurofilament corresponds to the disease severity as measured by the CMT neuropathy score. And we've shown the same thing by looking at fat in muscle with the 3-Dixon technique. And as you can see here, from mild to moderate severe, if you focus on this, you will not bring that back. It doesn't matter how clever your therapy is, you will not reverse that axonal damage. And I now am beginning to think perhaps that's what your brain looks like when you have axonal damage in a different way. So we need to treat early. And finally, we are humans. So that means that throughout our lifespan, we vary. So if you take a teenager, so this teenager needs to grow about a foot, or a little bit more, or a little bit less, depending on who you are. But that nerve has to grow in association with tendons, with ligaments, with bone, with muscles. So all of the work we've done on nerve transections and looking at factors is in isolation. So we need to work out what genes are being turned on at that stage to make that nerve work. So we need to remember the nerves are in a whole body. And secondly, they're in a whole lifespan. We know that certain genes will turn on in embryogenesis, other genes will turn on at puberty, and other genes will turn on to maintain the upper motor neurons and to maintain the nervous system later on. So when we're targeting therapies, we probably need to worry about when we're treating the patient along their lifespan pathway. That is extremely important. And the other thing is, humans are humans behaviourally. We don't do what we should do. So people give talks and say, we will solve this. We will find how to treat these inherited neuropathies. We will identify the patients, we will treat them, and we'll prevent the axonal loss. Well, we don't turn up for appointments. We've been told to come and talk before we get pregnant. We get pregnant. We drink too much. We eat too much. We are behaviourally humans. So we will always have to use a combination of therapies because we'll always see patients with the established disease as well as beforehand. And that will not change. And it makes me think of, again, going back to amyloid, that we will always need a combination of therapies. In amyloid, we had the surgical gene silencing with liver transplants. We have the new exciting medical gene therapies. We have TTR stabilizers, and we have therapies being developed to treat the established disease. And in all hereditary diseases, we will need that for humans, not only because of behavior, but because of de novo mutations. And that is a very important point to remember when we're talking about the utopia of genetic therapies. We'll also, because of that, need to have different ways of monitoring treatments depending on what disease stage you're treating the patient. And again, that will be extremely important. So I hope that I've tried to convince you that knowing about the phenotype and understanding genotype-phenotype correlations and never forgetting that we're dealing with humans is still extremely important. And I would suggest that in-depth phenotyping remains crucial to understand the pathogenesis of the disease and to develop rational and safe therapies. And finally, I'd just like to thank the people that I work with. This is our neuromuscular group. This is the inherited neuropathy research group, and I wanted to particularly mention the people whose work in my group that I've showed today. Jasper Morrow and Matt Evans for MRI, Maya and Emma for the HS1 work, and Alex Rosser for the retrograde axonal transport and neurofilament work. Thank you very much.
So thank you, Mary. That was, as always, superb. We have time now for questions. If you could state your name and where you're from. I actually cannot see because of the light. But I will ask the first question. So, as neuromuscular neurologists, we, clinically phenotype these patients with an emphasis on the peripheral nervous system, as you said. And so now with this new awareness of cognitive disability, you talked about MRI, but in my mind, MRI isn't really phenotyping the patient. So my question is, do you think there's a role now as a neuromuscular neurologist to do more deep cognitive phenotyping? And do you do that? And would it be helpful?
So I think that's a really good point. You may know Martin Rosser, who's the head of the Dementia Services in Queen's Square. So I joke with Martin Rosser that actually, I sometimes speak a little quickly, that if a patient can follow my instructions for a detailed, quick peripheral nervous system examination, that's equivalent to a cognitive test. So I think actually, the first thing is we do, if you think about it, how you do quickly ask them to do all those things. But I absolutely agree that we do need, sometimes it's quite obvious, they come with learning difficulties, but I think we do, because one of the issues is, I think as a community, learning difficulties is something we haven't done very well.
Right.
And actually, is it really static or is it progressive? So I do think we probably should start incorporating that in the phenotyping of our more complex patients. We do it at the moment by we have a setup to do neuropsychometry within our system, but we don't do it on every patient, and I think that is something we will start increasingly doing.
Are there any other questions? All right, well, if not, thank you so much, Mary. It was excellent. I'm very pleased to introduce our next speaker, Professor Peter van Doorn from the Netherlands, and he will be speaking on immune-mediated neuropathies, an expanding field of treatable neuropathies. Peter.
Well, thank you very much. First of all, I would like to thank the organizers for inviting me to this great meeting, and I will completely shift the subject now because we are talking about immune-mediated neuropathies, and it's really an expanding field of treatable neuropathies, and I would like to talk about that today. Well, these are my conflicts, which are mainly related to clinical trials in inflammatory neuropathies. Well, I sincerely believe that an amazing progress has been made over the couple of years, and mainly about understanding the immunopathology in inflammatory neuropathies. There are several groups around the world, for example, the group of Nobuhiro Yuki and Hugh Willison from Glasgow, who've really tremendously contributed to the understanding of the immunopathology. New antibodies have been found, very exciting new antibodies. Some of these are of the IgG4 class, which is another group than we normally see. New imaging techniques have been developed, and that's all led to the determination of new subgroups. Some of these subgroups seem to react much better after one of the specific treatments compared to the others. And an important issue, for example, in patients with Guillain-Barré syndrome, is that we have been able to make prognostic models that are of great help to determine the prognosis. And additionally, I would like to draw some attention for the fact that the European Academy of Neurology, in combination with the Peripheral Nerve Society, currently are making new guidelines for Guillain-Barré syndrome, and that we're going to revise the CRDP guidelines. Well, considering patients with immune-mediated neuropathies, it's very relevant to know a couple of things, as you know. One of these are the rate of and the duration of the progression. Others are whether the patients have symmetric or focal or multifocal abnormalities, whether it's predominantly proximal or more generalized, and whether there's pain or autonomic failure that can help you to make the diagnosis and to treat the patients. Additionally, of course, there's a larger relevance of the EMG, considering demyelinating or more axonal features. Well, this is more or less the traditional view in immune-mediated neuropathies. First, we have Guillain-Barré syndrome and chronic inflammatory demyelinating neuropathies, and then there is multifocal motor neuropathy, vasculitis, MGUS neuropathy, and POEMS. And I would like to focus today mainly on Guillain-Barré syndrome and CRDP. And I will try to talk with you about the fact that there are so many subgroups now within Guillain-Barré syndrome and within CRDP, and some of them need specific treatments, for example, patients with antibodies against nodal or paranodal proteins. First, Guillain-Barré syndrome. All of you are aware of the fact that mostly, and roughly 70% of the patients are post-infectious, rapidly progressive polyneuropathy. And the incidence, if you really count it on a worldwide base, then roughly 100,000 patients with Guillain-Barré syndrome every year get this terrible disorder. There's a large heterogeneity and a large range in severity of this syndrome. And if I might advise you, if you would like to read anything about Guillain-Barré syndrome, you can easily go to websites. You can download this book for free. It has been edited by Hugh Willison and John Goodfellow, and it describes many features that has been occurred over the past 100 years since Guillain-Barré syndrome has been described for the first time. Then the diagnostic criteria. There are epidemiological diagnostic criteria with James Sevier, but there are also more clinically important diagnostic criteria that has been set by David Cornblath and Art Esprit already almost 30 years ago. What is required? That is a progressive bilateral paresis of the arms and legs and reduced tendon reflexes. If a patient enters the clinic, you don't know whether the disease will exceed 4 weeks or not, but it's generally accepted that the duration of progression in GBS should not exceed 4 weeks. And then there is often a misunderstanding that CSF protein needs to be increased in GBS, which is not the case. And this is a graph from a study done by Chris Fokker from our group. And what you can see here is the number of patients. This is the number of days after onset of weakness. And in red is the proportion of elevated protein. So you can see if you wait long enough, then the chance that you have an increased protein is rather dramatically. But if you perform the lumbar puncture early after onset of weakness, then there is a pretty high chance that the cerebrospinal fluid is not yet elevated. So roughly 1/3 of the patients who've had a CSF protein examination have a normal CSF protein value. So that doesn't exclude the disease, but then it's mainly done to exclude other diseases because you're also looking for the numbers of cells. When there are a lot of established associations between various infections and GBS, and the most important one is Campylobacter jejuni, but there are also some others. And the new one is the hepatitis E virus, which can give a hepatitis and liver function elevation that occurs in roughly 1/20 of the GBS patients early in the course of disease. There's lots of debate about other viruses, for example, Zika virus, and it's highly likely that Zika virus is associated with GBS, but larger case control studies are currently going on. Well, why are all these antecedent infections relevant? First, this is the Campylobacter jejuni. It has been convincingly shown that antibodies are formed against epitopes on Campylobacter that cross-react with peripheral nerve. But that's not the only case. If you remember that many Campylobacter jejuni, for example, is the most frequent cause of bacterial diarrhea, and roughly 1 in 1,500 Campylobacter-infected patients finally get Guillain-Barré syndrome, so there must be other factors. Antibodies are relevant, especially antibodies against GM1, and they can cross-react with nerve, and the most evidence currently is in patients with the acute motor axonal neuropathy. Antibodies can fix on the nerve and can activate complement and cause nerve damage. So if we stay with the Campylobacter, and this is a graph from publication of Nobuhiro Yuki, and in this case this is Campylobacter bearing a GM1-like epitope on its surface, which can give rise to the Amen variety of GBS. And this is also a Campylobacter with a GK1B-like epitope on its surface and gives rise to Miller-Fisher syndrome. But as I already mentioned, it's not only the infection, there must be patient or host-related factors that are relevant for the development of GBS. Well, lots of studies have been done about antibodies in GBS, and this is a nice paper by one of the godfathers of Guillain-Barré syndrome, Richard Hughes, and others, and this is the relationship between the clinical varieties and the associated anti-ganglioside profiles that can be found. And very interestingly, the antibodies against gangliosides can activate complement, which can give disruption of various structures, including the nodes of Ranvier, the neuromuscular junction, and other neuronal glial membranes. So these antibodies can give rise to different varieties of GBS, this normal situation. This is the situation when you get axonal damage with GM1-related Amen, and this is the demyelinating feature of Guillain-Barré syndrome. So the antecedent infections at least partially determine the different type of GBS you get. Very interesting, some of the patients with GBS don't have antibodies, especially also not patients with Amen, and why not? And I would like to show you this graph of a study by Hugh Willison again, and this is neuromuscular junction. He convincingly showed in mice models that those antibodies can be removed from the circulation by the neuromuscular junction, by endocytosis, and go upstream to the central nervous system. And maybe that is one of the reasons that patients might develop Bickerstaff, brainstem, and encephalitis. So that's a combination of peripheral nerve involvement and central nervous system involvement. Well, what to do with those antibodies in clinical practice? Don't determine them too much, I would say. However, IgG anti-GK1B antibodies are clearly related to complex ataxic and brainstem syndromes and can be helpful when you consider Miller-Fisher syndrome, and can be helpful when it's not completely clear from the clinical picture. There are other antibodies, GD1B antibodies. They're related to Canomod and sensory ataxic neuropathy. GM1 antibodies, especially of the GM1, IgM GM1 antibodies, are related to multifocal motor neuropathy, so they can help to make the diagnosis. And in other cases, it improves the insight in immunopathology, and it may help to differentiate in pathological subtypes. So from a pathological, immunological point of view, they're relevant, and currently they will not determine whether you shift to another treatment or not. Well, I would like now to shift to CIDP and different categories of CIDP which are really emerging. But before doing that, I would like to go back a little bit to GBS. This is the classic GBS, what we normally know. And this is the paraplegic GBS, which can cause great clinical difficulties because of course, you would like to look for myelitis and other abnormalities in the central nervous system. There can be very focal varieties of GBS. This is the Miller-Fisher syndrome, and this Bickerstaff already talked a little bit about it. So we also looked to the paraplegic form of GBS, and Bianca van den Berg from our group did it. And some of the patients indeed develop a paraparesis at onset of disease, and sometimes you can already find some abnormalities in the arms, and sometimes in these patients EMG examination can really help, because if you find abnormalities in the arms, especially if you find demyelination, then you're absolutely sure that's a polyneuropathy. A couple of trials have been done, and it's a little bit a shame to say that the plasma exchange trials have been done already 30 years ago, and that's also for the IVIG trials. This is the plasma exchange trial. It's effective in GBS. It's not tremendously effective, but it's effective, especially if you perform a starting plasma exchange within the first 2 weeks after onset of weakness in patients who are unable to walk. The Dutch trial showed that immunoglobulin is as effective as plasma exchange. And in the other trial we did, we showed that the combination of IVIG with methylprednisolone is not more effective than IVIG alone. And David Kornblad will talk about a very new treatment, potentially new treatment in patients with GBS. Cochrane reviews are readily available, and so IVIG and PE are both effective. The combination is not superior, and steroids alone should not be given in patients with GBS. They can even do a little harm. This is the standard dosage everybody of us knows. Generally 5 days IVIG. And why 5 days? That was the initial IVIG treatment was in ITP, and it was 5 days because they started on Monday. And the plasma exchange, 4 or 5 exchanges generally. And the issue is a little bit what to do if a patient is already weak for 2 or 3 weeks. Then it has been shown that plasma exchange is still a little bit effective, and there are no data currently for IVIG. A very frequently asked question is whether you should treat mildly affected GBS patients. And the French trial showed that 2 plasma exchanges was more effective than no plasma exchange. And there is not a real scientific thought that if plasma exchange is effective, then it's likely that IVIG is also effective. So this is the most frequent course in patients with GBS, rapidly progressive. Most of the patients already reach the maximal weakness within 2 weeks after onset of disease. Then they gradually recover, not all of them so very well, unfortunately. And then roughly 10% of patients have a temporary increase in weakness. Then they have this is the improvement. Then you have a little bit more weakness. So these patients improve after you reinfuse IVIG again. And so it's an important task for you as a neurologist also to look very carefully in patients who are admitted at an ICU, who are almost fully paralyzed. If they improve a little bit and then they're worse again, they can have a treatment-related fluctuation, and these patients should be treated again with IVIG. And then roughly 5% of the patients finally turn out to have acute onset CRDP. That's important to realize, because once you have decided that's a CRDP, the patient should be treated as a CRDP, meaning you can also give corticosteroids then or regular IVIG infusions. So that's the acute onset CRDP. Remember, roughly 5% of the GBS patients, if you look back in series of CRDP patients, it's roughly 15% of the CRDP patients who have a rapidly progressive onset. When do you need to consider about a CRDP patient in patients who were diagnosed with GBS? That is, when there are more than 2 clinical relapses, or when a new relapse occurs after 2 months. So this is the course of disease in GBS again, some mild weakness, a very severe weakness, partial recovery, etc. And it's of great interest now with the evolving new treatments that we look very carefully at the patients who will do prognostically poor, because if you would like to give a better treatment, you would like to give it as soon as possible in order to avoid further nerve damage. So there are now prognostic models available for GBS, and I will discuss one only very shortly that can already be applied 1 week after onset of weakness. So if it's clear from the model, and the model has been tested rather extensively, if it's clear that the patient does have a poor prognosis, you might change treatment or give additional treatment. So this is the MEGOS score, which was developed by Christa Walgaard. And what is important, that's the age of the patient. If you're older, that's related with a poor prognosis. If you have diarrhea, which is poor, and this is the MRC sum score. So if you're weak, you have had diarrhea, and if you're a little bit older, then you have a more poor prognosis. So you can easily count after 1 week the MEGOS score, and you can easily read what your prognosis is to walk unaided after half a year. We currently use this model in the trial that's almost ready, in which we look for the value of a second dose IVIG in patients with a poor prognosis. You can also do it yourself and go to our website, gbsstudies.erasmusmc.nl. It's a safe website, and you can just fill in the figures and you go to one of the prognostic models. A very important issue I would like to draw your attention for is the fact that Bart Jacobs is leading a huge international study, the GBS outcome study, which is a prospective study running in 20 countries all over the world, gathering data of GBS, forming subgroups, and hopefully it will clearly lead to new treatments and prognostic models, etc. This is very shortly the trial we are currently doing. You can expect the data early next year, we believe. GBS patients are admitted, standard treatment is given. At day 7, we already use the MEGOS prognostic score. If they have a poor prognosis, they're randomized for a second IVIG course or placebo treatment, and then the other outcome criteria follow. So this is what's going on. Unfortunately, the study is only running in the Netherlands. meaning that it's not going that fast. That was because of the product, but that was only available in the Netherlands. And this is the numbers of patients included and randomized. And again, hopefully we can present the results in a couple of months now. Then I would now like to shift to CIDP and to the different subgroups. And please remember, making the diagnosis of CIDP is relatively difficult. Maybe not for you as a physician interested in neuromuscular disorders, but despite that, it is difficult. There's a clear guideline. There's a guideline which is headed by Peter van den Berg, and there are criteria to make CIDP, but despite that, to make the typical CIDP or atypical CIDP, it's not always very easy. This is shown by this publication by Jeff Allen a couple of years ago. These were patients who were referred to a large American center. It was thought that all these patients should have CIDP, and it's very important to realize that almost half of them had a completely other disorder. So the reason for that is not completely clear, maybe not following guidelines or other reasons. And I've seen no publications yet that we as Europeans do it better, but it's worrying. This was also a short publication on that in a recent Neurology Today. There's lots of misinterpretation, mainly of the conduction values of the peroneal nerve. As you know, if there is axonal damage, the nerve conduction velocity can be decreased already, and that might be one of the major reasons to make wrong diagnosis in patients with CIDP. This is a very important one. There are new diagnostic possibilities, and one of the possibilities is high-definition ultrasound and MRI. And Stefan Goudet is one of the persons who have really helped us to make life easier. This is the MRI, this is the high-definition ultrasound study, and this is the disease control. And what you can see in patients with CIDP, that nerves can be symmetrically enlarged on MRI studies, and it can be enlarged on the high-definition ultrasound studies, and in MMN patients it's more focal enlargement. The precise role of the ultrasound and MRI needs to be defined, and it's highly likely that they will be discussed also in the new EANPNS CIDP guidelines, but I'm pretty sure that they will be part of the guideline and that it will help us to make the diagnosis of CIDP. Importantly, these ultrasound studies were sometimes showed clearly enlarged nerves in patients who were clinically suspected to have CIDP, but in whom the EMG examination did not show demyelination. So if you really expect that the patient likely has CIDP, then, and the EMG examination is, let's say, negative, then I should suggest to perform good ultrasound studies. And they showed that one of the most interesting areas to investigate is the median nerve of the upper arm, because that gives the best discriminative values. This is a picture of ultrasound of the group of Ralph Gold, and it's also showing that ultrasound examination can help to diagnose CIDP. MRI can help to diagnose CIDP. Treatment for CIDP, yes, always try. And steroids in a number of regimens have shown to be effective in CIDP, but remember CIDP is a chronic disorder, so you need to give it for a prolonged period of time, and that might reflect in a prolonged chance to get side effects of corticosteroids. IVIG, yes, it's an effective treatment. It will not cure the patients, and some of our patients are now, we've tried everything, but we're now on IVIG for over 30 years, but without severe side effects, but it does not cure it. What you really would like to achieve and to use is a treatment that kills the disease. And maybe new treatments, and Dave Kornblad will talk about that, are more likely to cure the disease. Plasma exchange, yes, it's effective, but it's never a first choice. It only gives a temporary effect, and you should need to repeat it every couple of weeks. Now, as you know, that many immunosuppressants are being used, but there are no clinical trials that show an effect of other immunosuppressive agents. This is a, I think, nice study from Christa Kuitwaard, which we did together with Angelika Haan. It's a retrospective study, but in a large number of CIDP patients. And I would like to draw your attention for the fact that this is the first treatment in these patients was immunoglobulin. It was effective in 67%. But if the patients fail to improve and the second treatment was steroids, then still roughly half of the patients improve after a second treatment. And even if the second treatment was a negative, then the third treatment can help the patient. So the numbers in here are small, but I think the line is clear. You start with steroids or with IVIG. If the patient does not respond, then you need to go back and consider whether the diagnosis is okay. If one treatment of cycle of IVIG is ineffective, then it has been shown that some of the patients need a second cycle of IVIG treatment. And if there is then not an effect, and you're still sure that the patient has CIDP, then please try another treatment. And if that treatment is not effective, then try the third. Well, CIDP is far from homogeneous. There are a lot of different subgroups within the spectrum of CIDP. This is the typical CIDP. Weakness in arms and legs, proximally also involved. Then we have the acute onset CIDP I just discussed. Roughly 15 or maybe a little bit more % of CIDP have a relatively acute onset, so there's overlap with Guillain-Barré syndrome. Then there is a very distal form of CIDP called DADS, distal acquired demyelinating sensory neuropathy. Some of these patients have antibodies against MAG, myelin-associated glycoprotein, and some of these patients might respond after rituximab treatment. Then we have the patients with a paraprotein. If a patient with a clinically form of CIDP has an IgG protein and the hematologist tells you that's an MGUS, then it's fine. It's still within the spectrum of CIDP. However, if a patient has an IgM paraproteinemia with anti-MAG antibodies, that's considered to be not compatible with the diagnosis of CIDP. Then there are pure sensory CIDP patients, and a couple of them only have an ataxic form, in which the nerve conduction studies will not help you, and an SSAP might be helpful to show some signs of demyelination, and some of these patients are relatively rare, but they may improve after immunotreatment. Then we have the more focal forms, MAD-SAB or Lewis-Sumner syndrome. It's a multifocal demyelinating form of CIDP, and the pure motor form, they should be considered completely within the spectrum of CIDP. And it's remarkable that some of the patients with a pure motor form of CIDP can deteriorate after starting steroids. It's not known why, but we have seen it a couple of times. We have seen patients who became completely paralyzed after starting dexamethasone or high-dose steroids. We didn't believe it, so we tried it again at that time, and again, and complete paralysis. So if you have a CIDP patient with pure motor involvement, then I should be careful starting corticosteroids. Well, I would like to talk then a little bit more on this part of the graph, and that are relatively new forms of CIDP. Some of the patients have antibodies against proteins that are located at or near the node of Ranvier. A wealth of publications has been published over the past years. There are fantastic groups of Delmont, Deveau, Louis Carrerol, many others, Jean-Michel Vallat, etc. So it's a very interesting part of CIDP. And why? That is because of many of these patients have predominantly or exclusively IgG4 antibodies. IgG4 antibodies cannot fix complement and maybe need to be treated at another way than general CIDP patients. So this is from a nice publication of Femi and others in the JNMP this year. This is the normal situation. All of us knows what's going on. If you have segmental demyelination, there is current leakage and blockade of nerve conduction. And in axonal degeneration, there's also conduction failure, finally. This is what can happen if you have antibodies against nodal or paranodal proteins. What you can see is that there is paranodal myelin detachment. So these are the paranodal regions. If you have antibodies against these structures, there's detachment, there's there's increased nodal lengthening, and there is disruption of the ion channels. And it finally will turn out to give current leakage and nerve conduction failure. So this is what can happen. This is the normal situation, and patients can develop either axonal degeneration or demyelination. And if you have antibodies against nodal or paranodal proteins, there can be a conduction failure, acute conduction failure. If this is caused by antibodies, it can also only be very quickly reversible. So this is a very complex graph. I'm sorry to show it to you. I'm not an expert in this area, but I'll try to explain the localization of some of the relevant antigens in case of patient with CIDP or Guillain-Barré syndrome. So this is the node of Ranvier, this is the paranode, and this is the juxtaparanode, and then you have the internode. So this is the localization of GM1. GM1 is predominantly located at the node of Ranvier. GM1 is relevant in AMN patients. It's likely also relevant in multifocal motor neuropathy. And this is the localization of the NF155, Casper1, and Contactin-1. And some of the patients with CIDP have antibodies against these paranodal proteins. And then there are some other likely relevant antigens, Contactin-2 and Casper2. So these are the antibodies against nodal proteins. Antibodies against GM1 can fix complement. IgG4 antibodies are directed against structures that are located at the paranode or juxtaparanode, and they cannot fix complement. And maybe the fact that the IgG4 antibodies cannot fix complement could be a reason why IVIG is not or almost not effective in these patients. So this is also, I think, a nice graph. This is the normal situation. You see the NF155 and the Contactin-1. If there are antibodies against these structures, there's the detachment of the myelin from the axon. Then the question is, are these antibodies clinically relevant? And there are several groups, including Louis Carrerol and Deveau and others, who find subgroups of patients with CIDP who do have antibodies against one of these three proteins. NF155, these patients are relatively young, motor predominant, they have pretty much ataxia, they can have a tremor, and sometimes they also have signs of CNS involvement. if you go to the contactin group, these patients can have a relatively aggressive onset or a motor predominance. So all within the spectrum of CRDP. And antibodies against Caspr-1 are relatively rapidly progressive, also motor predominant and or pain. And especially, I think it's for us relatively easy to determine patients with the NF155, with the ataxia and the tremor. So if you have a CRDP patient with ataxia, tremor, and the other features of CRDP who do not respond properly after the proven effective treatment for CRDP, you should certainly consider these kind of antibodies in these patients. So that gives a huge spectrum of CRDP. It's far from heterogeneous, and that has also important implications when you're doing a trial. Not all of the patients within this spectrum, although they fulfill criteria for CRDP, are the same. And that gives implication for trial because you need more patients, or you need very clearly state the in- and exclusion criteria of these patients for your trial. I think the antibodies against the nodal, paranodal proteins are relevant. There's lots of information about it now, and I very much like this paper. And it's also stated that the IgG4 isotype antibodies are likely to be pathogenic in these patients. They do not activate complement, and indeed might partially explain why traditional treatment with RVIG is not effective in these patients. So this is the emerging spectrum of patients with CRDP. I didn't pay attention to MMN vasculitis, etc., but it's really a group of patients we need to consider. And I would like to finalize with a couple of issues. I think it's very important to realize that all the laboratory studies done by large groups around the globe, for example, your Willison's group and other groups, have really helped us to understand the pathogenesis of Guillain-Barré syndrome, and to a less extent, unfortunately, in patients with CRDP and in other immune neuropathies, but it has made great progress over the past, let's say, 10 years. The diagnosis of these immune-mediated neuropathies is not always easy. Therefore, it's very important that guidelines will be made and guidelines will be followed. I showed you the graph of the publication by Jeff Allen from the United States, showing that 50% of the patients suspected to have CRDP had another disorder, and sometimes a completely other disorder. To make the diagnosis, EMG examination extremely important, but be alert. Not all decreased nerve conduction velocities imply that it's demyelinating neuropathy and that it's automatically CRDP. Some of the patients looks like CRDP, but EMG examination doesn't show it. If that's the case, but also in some other patients, ultrasound and maybe well-performed MRI studies can be of help to make the diagnosis. In some of the patients with CRDP, especially CRDP, specific antibodies against these nodal paranodal proteins can be relevant. If you look to GBS, antibodies can be relevant, but only in a very minority of patients. Patients with Miller-Fisher syndrome, it can be helpful, and in some chronic disorders, it can be helpful. Prognostic models, and I only showed you a prognostic model called M-EAGLES, which determines the chance that you're able to walk after half a year, are very relevant. But they need to be checked. We made that model with a Dutch population. It was checked with the international European population, but it's not for sure that all those models are also valuable in Japan or in China. And hopefully, the IGOS study will help to make new prognostic models, to check the prognostic models also for other areas in the world. Treatment. Yes, there's clearly treatment. It's our immune-mediated neuropathies, and they are treatable. In GBS, however, we are rather unsuccessful in treating it very properly. By using the traditional IVIG or PE regimens, 25% of the patients still need to go to the ICU for artificial ventilation. 20% of patients still unable to walk after half a year. So are we very good? No, we are not. We are a little bit, but we need to do better. And hopefully the SIT GBS study will help if we can show that some of the patients with a poor prognosis might benefit from a second course of IVIG. And there is an important other issue that will be discussed in the next presentation by David Kornblath. There are now new components that could, if it's shown, clearly shown, that potentially could be very valuable for patients with GBS. So it's a very exciting area at this moment. And I would like to draw again your attention for the fact, please use guidelines, please promote the use of guidelines, and new guidelines will appear in 1.5 years. Well, I would like to thank you for your attention this morning, and I would like to draw some attention for these meetings of the Peripheral Nerve Society. The next meeting is in a couple of weeks. Maybe there's still some room to register in Baltimore, and the meeting next year will be organized by our Italian colleagues in Genova. Thank you very much for your attention.
Thank you very much, Peter, for an excellent, comprehensive talk. And now we're open to questions. Can I just start with one easy question, Peter?
Please, an easy
Why
question.
do steroids not work for GBS and the motor, multifocal and motor CIDP? Why don't they work, and why do they make it worse?
Okay, that was your easy question.
That was tongue-in-cheek easy.
I don't know. I wish I could give an answer to that, and it's remarkable that that's the case. It's also remarkable that steroids don't work in GBS.
Amazing.
I don't know. Maybe you have a suggestion.
No, I'd like you to answer for me, though. I think it's telling us something pathogenetically that I don't understand. I think Eva has a question.
Yeah, I do. So, Peter, I thought your slide indicating that I think it was 49% of patients we believe have CIDP actually have an alternative disorder made me wonder, are you using nerve biopsies anymore? And do you feel there's a role for nerve biopsies, something that we used to do a great deal, say 20 years ago, that really I think its use has definitely decreased?
Yeah. Well, thank you. This is an important question, the relevance of nerve biopsies in these disorders. I think the indication is extremely limited, but in some patients in who you completely don't understand what's going on, sometimes it can be useful, but in our clinic, we are we are performing very low numbers of nerve biopsies anymore because it harms the patients. It's nice to know, but it harms the patients. But if you are in doubt, if it is important to make important clinical decisions, then I think, yes, there is still room.
Are there any other questions that we've won here? Please.
Thank you for that excellent overview. To make the steroid question a little bit more complicated, we are now seeing patients who are on immune checkpoint inhibitors treated with, and they have this sort of spectrum of neuromuscular complications, including GBS-like presentation, who seem to respond to steroids. Do you have any comments?
Good question.
Yeah, thank you for your question. In GBS, it's always very difficult to consider whether a patient is improving after a certain medication or whether it's spontaneous improvement, because the nature of the disease, of course, is spontaneous improvement after a period of time.
Any further questions? If not, I have another one, Peter. So basically, I think it's interesting, and as you said, the new guidelines for CIDP are likely to include imaging, MRI or ultrasound. But I have a bias for my practice, of course, seeing those difficult patients whose history is 3 or 4 years, so subacute, and it still could be hereditary, who don't have a gene. So I think the hereditary versus the inflammatory, it may be that we have to come up with a rapid onset CMT1 CIDP panel or something, because I think it is, in practice, a question in a subgroup of patients that makes that difficult.
Yeah, I think you raise a very important point, and enlargement of nerves is not exclusive an element of an inflammatory neuropathy. It can also occur in some of the other disorders, and CMT is one of them. So everybody needs to take care, of course, first with clinical examination, family history, and you especially need to take care when the patient does not fulfill your expectations when you start treatment.
Any further questions? If not, I'd like to thank Peter very much for that talk. And now the final talk this morning is on advances in the treatment of peripheral neuropathy, and we cannot think of anyone better to give this than David Kornblatt, who has an interest in all kinds of neuropathy and expertise in them. Thanks, David. David is from Johns Hopkins in the US.
Whoa, thanks. It's incredible. I never figure out how these people can talk up here. You can't see anything, you're completely blinded, but I guess they learn. Anyway, I'd like to thank the organizers. Wolfgang Grieswold is right in the front. I'm going to give him a personal round of applause. It's an extraordinary meeting from a group that's done really well. Wolfgang. So, gosh. Yeah. I'm looking down, I'm going, gosh, really? I think I've got the wrong slide set, guys. Maybe I could get the right one. Yeah? There we go. We're getting close. Yeah, there we go. Okay, perfect. There we go. Okay. So anyway, I'd like to also thank the organizers, and I'm going to be I'll go a little bit quicker. But I'd like to talk about new treatment, which is something I've been quite interested in. And again, I'm not sure whether there's any possibility of getting that light turned down a little bit, the one that's in my face. I'm sorry, I just can't even see below me. So I have a large number of conflicts of interest, as the number of my friends say, and my standard US joke would be, if you don't see your name there, I'll meet you at the end of the room after the talk, but please bring cash. So I think one of the things I'd like to make is sort of an amazing progress story that has come out in the last year or so. Again, largely in cooperation with people in the Peripheral Nerve Society, elsewhere, but our friends in industry have worked very hard to help us make what I think is an amazing progress. And I'm going to go through this, and you can see that in each of these, so I'm going to talk about sub-Q, which has been done in conjunction with our friends at CSL, some interesting stuff that's been done now in GBS with small volume plasma exchange. Dr. Meena, who's over here in the front row, has been involved in this for at least 20 years that I know of, and the group in Bangladesh has now moved it forward. There's some very interesting work you heard about briefly on complement in GBS, just been published in Lancet Neurology. I'd like to talk about some new ideas that I'd like to propose for GBS. And lastly, I got beat up this week as I was coming over here the night before I left. In the New England Journal, for people who haven't seen it, the two articles of the two papers that I'm going to briefly talk about at the end, and then an accompanying editorial on the new treatments in familial amyloid. So Peter talked about IVIG. We know that it's useful in both treatment and maintenance, and now we know that subcutaneous IG is just as useful, and this is the study led by Ivo van Schleich and Aurel Merkel, who at CSL, who did this very large multi-center randomized controlled study looking at subcutaneous IG instead of IVIG. And I'm going to show you some of the data, but then get really to the important points of what it sort of means for us in practice. So this is a design. The design was built on the infamous ICE trial, where they took people now here, the laser pointer. So these are people who are put into the study because their clinicians think they have CIDP. And we heard from Peter that this is a very difficult problem. Jeff Allen has shown that 50% of the patients referred to him for CIDP don't have it. But there are two additional papers, again, sorry, I apologize, they're both from the United States, in which people did audits of patients who were getting IVIG through infusion companies And they went and they audited the medical records of the people who were on treatment with IVIG under infusion companies. And for people who aren't from the United States, you have to understand how this works. A doctor writes a prescription, the prescription goes to the infusion company buys IVIG for, say, $5,000 and infuses it for $10,000. So the infusion company, we call them middlemen or bloodsuckers, I can't remember which, they're making a ton of money keeping patients getting infused. So in 2 studies now, it's been shown that the number of people who are getting infused in the United States by infusion companies, the number of people with CIDP as determined by experts, external, is somewhere between 10 and 30%. So in one study, 90% of the people couldn't be confirmed, and in another study, 70% couldn't be confirmed. So it's a giant problem, at least in the United States. So to deal with that problem, in this study, there was an IgG dependency test. So people who were referred into this study were taken off their IVIG in an unblinded fashion. That is, I'm getting my IVIG, I join the study, and they say, that's it, David, you get your last dose, the dose ends, and off you go, and you see if you decline. And what you see is, in fact, that not everybody declines. So that there are a number of people out there who are getting their IVIG, even with the best physicians, we think, who either don't have CIDP or no longer need their IVIG. So one of the things in the guidelines is, as a good practice point, you should always be trying to get your patients off their IVIG. What's interesting about this study is that after they were gotten off their IVIG, if they declined, they could be they were fixed up with IgG again, which most of them got, and we have a paper, I guess I can't remember if it's in press or about to be published, on this, and then they were restabilized, and then they were put into the blinded study over here. So now I'm a patient, I get my IVIG taken away in an unblinded fashion, I know I'm unblinded, I get worse, because I know my IVIG was taken away. I get better with IVIG, and now I'm put back in the placebo, but now I'm in an unblinded withdrawal phase, and there are people who don't get worse. So it's a very interesting concept. If anybody can understand it, because it's not quite placebo, I'm not sure what the words are, but in an unblinded fashion, you get off your IVIG, you get worse, but when you get off your IVIG in a blinded fashion, you don't get worse in a very short period of time. I think it's extremely interesting, but something we ought to think about as we try to take our patients off. Should we take them off in a blinded and unblinded fashion? And there's a study going on in the Dutch to look at this. So this is a study. It all looks exactly what you would think. Here's the patients. It shows how they got on, then they got their treatments, relatively equal numbers of placebo, low dose, and high dose. And the doses are around the standard ICE dose of about 1 gram per kilogram every 3 weeks, 1 dose a little lower, 1 dose a little higher when you work it out. And so this is the primary data. What you can see is that the placebo people relapse, but again, look at the number of relapses. It's 56%. And those relapses are prevented by the 2 doses of subcutaneous IG, maybe a little bit more, but not statistically significant with the higher dose. But we all know from our clinical practice that there are patients who are requiring higher doses than 1 gram per kilogram every 3 weeks, but there are plenty who do quite well on lower doses. So again, another good practice point, we should be trying to get our patients either off or to the lowest dose that they need. So these are the time to primary outcome, and the important part here I'd like to bring up is in this, in that most people who are going to relapse relatively quickly. Most will relapse within about 4 weeks, the vast majority by 8 weeks, very, very rare after that. So if you take somebody off IVIG or subcutaneous IG in the future and you want to reassure them, you just make them a frequent visit. You say, come back in 2 weeks, come back in 4 weeks, because that's the time you're at risk. Don't make a 3 or 6 month follow-up. Adverse events, as you can imagine, are relatively low. And if you look at this list, what you see is a different profile than all of us are quite experienced with IVIG, which is the sort of headache, sort of meningitic type syndrome. Basically, it just doesn't happen with this product. People have some mild injection site reactions, but those go away relatively quickly. Patients considered relatively easy to use. I'm not sure how many people in the room have experience with subcutaneous IG. There's one I know, but anybody else? Many people? Not many, a few. So anyway, it's relatively easy. Patients put a bunch of needles under their skin. They sit around, they watch movies, they do what they like, and off they go. They do it at home, they do it themselves. It's relatively easy. So what did we learn from this study? We learned that the majority will remain relapse-free at high dose. A large number will remain relapse-free at the low dose. Again, it's not statistically different, but the high dose did perform a little bit better at most of the places. Secondary outcomes were, again, quite good in terms of all those usual things that we look at, and they're safe and well tolerated in terms of the doses. So it is an alternative to consider, particularly in people who travel a lot, because you can take this stuff on the airplane with you and go wherever you want, to the meetings, places like this. You can sit in the room in the back and infuse yourself as long as you have sort of a sweatshirt covering the pump. But again, many people who we, and I'm including myself, all of us have on IVIG just don't need it. And we really have got to do a much better job in this idea of diagnosis. Pretty soon there'll be the long-term extension study from this, which will support the conclusions I've just told you. Now I'm going to jump a little bit to GBS, and yesterday Mary told me that one of my talks I'd given in the past she really liked, and I think she liked it because I'm a relatively simple guy, so I try to make things a little bit simple. So I'm going to try and make GBS simple so that we can use this simplistic way to move forward. So as Peter suggested, GBS is caused by these autoantibodies. They're contained in the IgG fraction of blood, and that they affect themselves at least partly through mediation of complement. Not the IgG4 in CIDP, but in GBS, they're mostly affected by complement work shown decades ago by Jack Griffin. And so plasma exchange works by removing the IgG, right? And so it throws it away, but it also takes out complement. So that seems to be reasonable. And IVIG, intravenous immunoglobulin, and it works with interfering with this stuff. So if we can accept that as relatively simplified, we can now move on to what I'm going to talk about in terms of both actual and upcoming treatments. So I don't know how many people in the room know what is a course of IVIG for GBS cost. So at least in America, it's in the neighborhood of about US dollars 15,000. A course of plasma exchange is again about US dollars 15,000. And so it makes it impractical for many parts of the world. And again, I want to highlight Dr. Mina's work from India and others from India, but more recently the group from Bangladesh has moved forward to try and overcome this. And what they've tried to do is to say, well, maybe we don't have to buy one of the fancy machines from Terumo BCT, which costs somewhere between $50,000 and $100,000, but we could do it ourselves using essentially exchange transfusion. So we'll do multiple exchange transfusions during the day. We'll take out a unit of blood, we'll hang it up, we'll let it separate, as we sort of say simply, we'll throw away the yellow part and we'll reinfuse the red part back into you. And we can do this multiple times during the day because we know, and this is an important part, because we know that when we throw out the yellow, we're getting rid of some of the clotting factors, we'll give back some fresh frozen plasma, and that'll help. And we can do this thing multiple times. And maybe if we do it, we could do a study of it in a feasibility study, to which I'm showing you here. We could do it to see if it's feasible to do before we do a randomized controlled trial. And so what they did was a feasibility trial, and if you look here at the secondary endpoints, everybody in the room recognized these as fairly common for getting blood drawn and certainly for getting plasmapheresis. They wouldn't distress us in any way. One patient got shock, but here's the important thing, that is you'd like to know how this compares to a standard course of plasma exchange. And so if you take this, they looked at 8 liters. Probably when the studies were done in North America and France, the volume was a little bit larger, probably closer to 12 liters in total. And you can see this exchange rate at 140, and you saw from Peter's slide in the North American and French studies, it was about 150 to closer to 250. So this is a little bit light, L-I-T-E, on plasma exchange. And if you looked, again, there's just no control group, but these figures look pretty good. 55, half of them were walking unaided after 4 weeks, 75% were walking unaided after 6 months. Looks pretty good. Obviously, it's not a control. So what they concluded in the study was that, geez, it looks safe, it's feasible, and it only costs, look at the cost, $500 US. So this could revolutionize the treatment of GBS in parts of the world where it's not done. 2 caveats, of course, for this are, as I mentioned, the plasma exchange volume is so-called on the light side, L-I-T-E. It's down probably around 8 liters versus the more standard 12. And as importantly, in the fresh frozen plasma, there is IgG. And when you calculate up how much IgG these patients are getting through the fresh frozen plasma, it's about a half standard dose. It's about 1 gram per kilogram. So this is really a treatment of low volume, small volume plasma exchange, i.e. about 3/4 of a standard, plus half dose IVIG. Yet look what happens to the cost, comes way down to nothing. So this has the opportunity to revolutionize not both in resource poor countries, but maybe if it really works, be something to be thinking about in our countries. So the next thing I'd like to talk about is complement, and what is extraordinary about complement is it went from these human observations, which we did in our Chinese work, to animal models, Ulison, and back to the treatment. We can treat GBS with complement blockers. There's 2 completed trials of eculizumab, and there are many other drugs under consideration. So this is a study that's just been published, you can see in April in Lancet Neurology, was done by the Japanese, the so-called JET GBS trial, based on a trial protocol provided by Hugh Willison and his ACA GBS trial. So they used the hyper-expensive, sorry, I'm not sure if they're in the room, but at one point this company had the, I guess, dubious honor, we would call it, of being the most expensive drug in the world at $800,000 US per year. Fortunately for our disease, that is for GBS, we're only going to use 4 doses, so you can figure out, somebody can do the math pretty quickly, of a 1/12 of 800,000. Still not so cheap, and I think this is something we should consider as people start to tell me to use this drug in myasthenia gravis. So this was the one that was used, and the study design is relatively simple, which I think is, maybe it's on the next, no, anyway. The study design is relatively simple. You entered this study, and you either got placebo or you got 4 doses of eculizumab, 1 a week. You got your IVIG in both arms, but you got eculizumab once a week with prophylaxis for the Neisseria meningitis. And the main thing was looking at safety and outcome. This was a 2-to-1 randomization study, a very, very small pilot study. And here are the adverse events. They're pretty equal. One adverse event everybody always points out looks pretty terrible, right? Intracranial hemorrhage, but this was assessed by an independent data safety monitoring board as being unrelated to the study treatment, brain abscess. It was the same patient. So there's no significant differences, no deaths, and all the AEs resolved. So it appeared again in this very small pilot study to be safe, and there is lots and lots of experience with eculizumab given by itself to know what its adverse event profile will look like. Now, one of the things that I'm going to show you is that in this study, because it was a pilot, there are no p-values, okay? the study was too small, and so there weren't really p-values, and I'm not going to show you any. This is the proportion of people able to walk independently at week 4. The red in all these slides is going to be the eculizumab group, so it's 65 versus 45. If you look at the functional grade, and people like Peter Van Doorn are quite used to these sort of curves, they should go down. You can see you'd like to be on the bottom half. That is, you would like your functional grade over time to be getting closer to normal. But again, the error bars are quite large given the number of subjects. This is the proportion of patients walking, and you saw this in the MEGO slide, so you'd like to be on the upper end of this. Again, it seems to be higher in the eculizumab group. And the most extraordinary one is this one, in my view, which is the proportion of patients able to run. And when I saw this slide, and it looks really dramatic, right? The proportion of running people is able to run is way up here at almost 80% for the treated group and down to 20. I asked, of course, being a skeptic, I said, so did you ask them if they could run, or did you make them run in the hallway? And I was assured that they made them run in the hallway. It wasn't just a subjective question, can you run or not, because patients aren't so good on that kind of stuff. So it looks pretty interesting. That is, eculizumab added to IVIG appears to be safe. There appears to be a marked improvement in motor function. Again, no p-values, but the data look pretty good. Maybe what we're doing is blocking all the complement-mediated axonal damage that has been shown multiple times, and that we'd really like Alexion to sponsor a phase 3 trial. Now, the interesting thing is, of course, it's not just Alexion we can talk to, but we can talk to and are talking to quite a number of other companies, all of whom are developing monoclonals against parts of the complement pathway. And I'm going to particularly point out here this company called Annexon, who's moving rapidly ahead in this field, is much further along than virtually anybody in moving into clinical trials in GBS. This company, which used to be True North and then was BioVerative and has now been bought by Sanofi, is also quite interested. And so we're hoping that there are other companies, aside from maybe 800,000 a year, that we could interest in treating GBS. Because again, we think you'd only need a few treatments at the beginning, and then you could turn the treatment off. Now, what are other things that we might consider for GBS and/or are being considered? As I say, if I had GBS tomorrow, what would I want? I would probably say to my colleagues at Hopkins, I'd say, look, here's what I want. I'd like you to pherese me for 2 days, day 1, Monday and Tuesday, try and drive my IVIG, throw all the bad ones out as much as you can quickly, and then very quickly right thereafter, I'd like to get IVIG to mop up all the other stuff. So I've talked extensively to Terumo BCT about this, as I think it would be a very interesting, novel study. Safety is well known, and we could see whether trying to get rid of some of the IVIG at the beginning might work. There's a company that's actually moving forward on this called Hansa Med, and let me just make sure there's the study. They have this bacterial enzyme, IDAS, which does the following, as you can see here. It essentially cleaves the IgG molecule. So there are 2 steps to it. It cleaves at 1, cleaves at 2, and then it's off. And as a result, if you give a single dose of this stuff, and this is shown here, these are IgG levels in a phase 1 study in healthy volunteers, essentially you have no IgG at the end of the day. So you get the stuff in the morning, by the end of the afternoon, your IgG is essentially gone. Now the stuff stays in your circulation, crushing out your IgG for a day or 2, so you can't give IVIG right after it because it would all get degraded just like regular. So you have to wait a day or 2, and a number of us in this room have been consulting with Hansa about moving ahead, and we're hoping that they'll move ahead with a European GBS study where you give 1 dose of their IDAS, drop this, and then come in a day or 2 or 3 later with standard IVIG, which won't get degraded. And so that's, to me, a very interesting idea. Now, it turns out that we heard why earlier IVIG is given for 5 days in a row, right? Because in the original studies, right, it was given on Monday, and we only worked in those days for 5 days. But now we also, how many people know why the half-life of IgG in the circulation is 21 days? And it's because of this fetal neonatal receptor that prevents the degradation of IgG in the bloodstream. So IgG comes in and attaches to this receptor, and it doesn't goes to the lysosome, but rather goes through and goes back out again. And that's why the half-life of IgG is 21 days in a simplistic way. So if you could block this using a blocker, you could increase the degradation of IgG in a rather normal way. So here it is. These blockers promotes the degradation, and some of them appear to have other aspects in the immune system, particularly the one being developed by Syntimmune, but there are multiple other companies who have these blockers, and this just happens to be the Syntimmune data. You can get similar data from several of the other companies, and so if you give their product, look what happens. IgG is down to 60% at the end of the week. So that's better than plasmapheresis, which you give for 2 weeks and takes it down again to about 60 or so percent at the end of the 2 weeks, where you reach an asymptote and you can't go any further, which is again why we stop plasma exchange for GBS after 2 weeks. But here you could do this, drop it way down, and essentially do a plasma exchange. And multiple of the companies have been thinking about this drug both in GBS and CIDP, not just the Syntimmune people again, but there are others who are doing this. Now, the last thing I'm going to turn to is TTR. To me, this is just extraordinary. The progress is amazing. I've been involved with both companies as a consultant to Alnylam, but on the Data Safety Monitoring Board for Ionis, which probably you missed on the first slide. So Mary has talked about it, a rare, inherited but rapidly progressive disease. If you get one of the bad forms, you die usually within about 10 years, but some of the survival is limited. It's a multi-system disease. Now with gene testing, we're able to detect more and more of these people, probably at an earlier stage than clearly we used to, and marked clinical manifestations. And as Mary showed you in that really nice slide, the treatment options, although she showed you where they start at the beginning with the liver transplant and then move to tafamidis and difluzinol, they're okay. The problem with liver transplant is you're on immunosuppressants for the rest of your life and all the things that go with it. So the question was, and this is from Michael Polydefkis, now showing that in fact you can diagnose amyloid in a skin biopsy. So one of the things we've now started to do on every skin biopsy we're doing amyloid staining. I think some of the other companies in America reported that they were doing amyloid staining, but were never convinced that actually they could do it. But it can be done. So this is a slide actually from the New England Journal paper, and as I think I may have mentioned, 2 papers came out this last, Tuesday or Wednesday. The Alnylam paper, the Ionis paper, and this slide is from the editorial, which is about it. I'm not going to spend any time other than to say, if you're really interested, I would suggest you look at the 2 primary papers. The editorial, I must admit, Davide Parison and I were talking, it's a little negative. I was surprised it's so negative, but I don't think the data is negative. So there were essentially 2 studies done in parallel, one by Ionis and the other by Alnylam. One used the antisense technology, and the other used the RNA interference technology. And you can read quickly about it. The essential idea is that both of them dramatically lower TTR. The studies were identical, and the way I'm going to present them is essentially sort of in parallel, but showing you where they were similar. And they were similar because they both went before the US FDA, And so the FDA likes to think like me simply. So they said, well, we got 2 trials, same disease. We'll just use all the same stuff. We're not going to make our lives difficult. So both enrolled worldwide, both enrolled many mutations, although at least half in both the studies were the Val30 MET mutation. Both studies used the same endpoints. Both studies reduced circulating TTR dramatically. And in my view, both studies were wildly positive in meeting their primary endpoints. And in some of the slides, I don't think I put in all the zeros for the p-values because they're so dramatic. So this is the NeuroTTR study by Ionis. Essentially, you're going to see the same thing. You're screened, you're stratified. Here's the stratification, stage 1, 2, although most of the patients were stage 2. Again, half the mutations were the V30 MET, and you were stratified whether you had had previous treatment with one of the 2, tafamidis or diflunisal. And then typical, randomized out, and off you went in a 15-month trial with now the open label follow-up continuing. The primary endpoints for both are this so-called modified neuropathy impairment score +7, and with all due respect to my friend Peter Dick, who I respect in all ways, I can't understand it. It seems to me a statistical construct. It mixes apples, oranges, but only a slice of one orange, but a peel of the other apple, etc. But he's shown that it's worked, and the FDA accepted it. I'm really not sure if anybody in the room could help me understand it. The other primary endpoint was a diabetic neuropathy quality of life scale, but again, widely accepted by the FDA because it's been used multiple times in failed diabetic studies. So these were the 2 primary endpoints, but as you'll see, it really doesn't matter. When a drug works, it works, and you can have anything. So there they are. There's what they measure. Quality of life, the MNIS +7, which I think many people, based on the laughter, understand. So here's the study. Both primary endpoints for the Ionis study showed robust and highly statistically significant benefit versus placebo. The benefit was across mutations, disease stage, and whether you had been treated or not. The clinical measures and the quality of life went hand in hand. Again, as I mentioned, I was on the Data Safety Monitoring Board. There were quite considerable problems at the beginning with renal dysfunction and thrombocytopenia, particularly renal dysfunction. And so a series of enhanced monitoring were done. Frequently, you have renal function. Frequently, you have platelet monitoring done. And that has prevented further serious adverse events. So that the safety issues, again, I'm speaking as a member of the board, were identified, monitorable, and now are considered by us to be quite manageable. The Alnylam study was quite similar, resulted in very large and significant improvements in all of these measures, motor, sensory, and autonomic output across TTR, disease severity, genotypes, included patients with cardiac disease, and the cardiac function changes, which were exploratory, seemed to also improve. And here you can see them if you're a cardiologist. Again, very well tolerated, nothing particularly great, peripheral edema, and these infusion-related reactions because this is given IV. So where are we? I think, again, we've made enormous progress in the last year or 2. All of this is now published. When I first sort of put the slide set together, some of the stuff was getting together. The Hizentra subcutaneous stuff wasn't yet published. It's been published now in Lancet Neurology at the beginning of the year. We're looking very much forward to moving ahead with larger trials of this small volume plasma exchange. I personally prefer to call it light plasma exchange plus light IVIG because it has 3/4 of the dose of plasma exchange plus half the dose of IVIG for GBS, but the cost is trivial, and a large trial in Bangladesh is going to be a move forward. The exciting results from, again, going back to the clinical data from Jack Griffin through the experimental data of Hugh Willison to the clinical trial suggests that blocking complement in GBS may be something really dramatically different, added on to what we're currently doing, and we need Alexion to step up, and if not, we know Annexon is already stepping up and maybe other companies will pursue this. There's some other ideas in GBS, as I've shown you. The Hansa Medical one is moving ahead, and maybe one of the FcRn blocker companies will step forward. And now we know that TTR FAP can be very much slowed by either of the two treatments. And what we're now going to do is need, as clinicians, to get experience with these, move them into the clinic, and help our patients dramatically. And so the last slide, you've seen this. If you'd like to come to Baltimore, we'd love to have you. The Ravens will not be playing, but the Orioles will be playing, and we're going to be going to a baseball game. So thank you very much, and hope to see you there.
Thank you very much, David, for an excellent talk. Now we'll start the questions. Perhaps I can just ask a very quick one first. What is your theory as to that issue in the PATH study about the people before the study not responders and then the placebo difference? Because that's a really difficult issue going forward with trials.
Yeah, so Mary asked about this issue, and about if you're unblinded and you get off your IVIG, you get worse, but then you get restabilized, and shortly thereafter, if you're blinded and taken off your IVIG, you don't get worse. I talked to some friends. It's not placebo, because that's not the right term. I still think it's psychically mediated. That's my personal view, but I don't get a lot of support from that. One hypothesis has been is that these were people who were really close to being able to get off, and in the middle between the two periods, they actually got a ton of IVIG, and that allowed them to get off a second time. But I just think it's fascinating.
Thank you. Maybe Eva next, and then I see somebody.
So David, I haven't read the two papers, the two amyloid papers yet. Can I ask, what was the length of treatment in those trials, and when, or maybe the data are in the papers, when did they begin to see improvement? I'm sure that the primary endpoint was met at, say, I don't know, a year, 2 years, I don't know the length, but are there any data about when you first begin to see a change?
The primary treatment trial was 15 months, but both are in very large, long, open-label extensions that are ongoing that are going to go for at least 5 years for the people who were in it. Davide, I can't remember. I thought the separation is early. It's early, in months, right? Months. That's what I remember from the curves.
Thank you very much. There's a question here.
Yeah, David, great talk. Brian Callahan from the University of Michigan. I was curious if we know what the costs of the sub-Q IVIG is, and I mentioned that because a lot of times when we come up with new technology, a lot of times even though it might be cheaper to produce it, the costs kind of rise to the comparable therapy, such as giving traditional IVIG. And we also currently don't know how IVIG compares to sub-Q IVIG at this time.
Yeah, so my understanding is based on the patients I've moved over to it, it's close, maybe a teeny bit more, but it's certainly not half the price. It's not 3/4. It's either 100% or 110 or 95. It's in that range. And at least, and maybe there are other people in the room who have experience using it, it seems to work pretty much just the same. Patients of mine who've stopped it for convenience purposes. They didn't like it. They didn't like the procedure.
Other questions, comments? It's great to have a talk with lots of positive treatments for neuropathy, and actually all published. What a fantastic field.
It's just incredible.
Well, maybe on that note, if there are no further questions, just to thank David and to thank all the speakers for this morning, particularly for keeping on time and for great talks. Thank you.